John Weigeld, your coordinating editor for CSAP 17 Audio Companion. I've asked Dr. Travis Webb, one of our CSAP 17 authors, to speak with me today. Travis, before we really get started, can you share with our audience where you are located, your primary focus of clinical practice, and maybe a little bit how you spend your usual day, if there is one of those?
Sure. Good morning, Dr. Weigelt. I am a professor of surgery at the Medical College of Wisconsin in Milwaukee. I've been here for actually about 20 years in total, but I've been practicing acute care surgeon doing trauma, critical care, and emergency general surgery here since 2005. So in that practice, I do work at a level 1 trauma center. And so we have a very busy trauma practice as well as emergency general surgery, and as well as we cover the surgical intensive care unit. So typically I spend about a week every month covering one of those services. I also do have a general surgery elective practice, which over the years has really kind of been whittled down to mostly elective gallbladders, lumps and bumps, and then a lot of abdominal wall reconstructions and hernias. We do have a intraocutaneous fistula practice here, so I lead the charge in that. I'm a little bit reticent to advertise that too much, but we've got a great program taking care of those very complicated patients.
And if I remember right, you're also associated with developing a rural track for the medical school. Is that correct?
That is correct. So half of my time is actually spent as the Associate Dean for Curriculum here at the Medical College of Wisconsin. And in that work, we have actually 2 regional campuses up in Green Bay and Wausau, Wisconsin, where we graduate students after just 3 years of medical school with the primary focus of getting them into primary care types of specialties. And we've defined primary care as both family medicine as well as psychiatry and surgery. And we're in about our 4th year of that, and things are going really well thus far, and really excited about it.
Yeah, I think it's a unique idea to repopulate some of those activities that are slowly being taken away from us as those of us who are elders, like myself, retire.
Right. Yeah, I think it's an important endeavor that we're trying to get our students interested and focused in taking care of patients out in the real community out there, and there are a lot of opportunities in smaller communities for physicians to go out and practice. Great.
Well, thanks for all that information, and I have asked you to share some of your thoughts about various conditions a general surgeon faces. We will be discussing topics that actually are in CSAP 17 in the abdomen category. Some of the topics are right from CSAP 17 questions, and others will be questions that were written but were not selected for the final draft of CSAP 17. As you well know, some of our discussions at the committees are extremely energetic, I will call them, and bring up topics that sometimes don't always make it into CSAP. But I think general surgeons listening may find themselves confronted with a lot of the things we're going to be talking about. So let's get started. I want to start with what used to be an easy topic, appendicitis. So uncomplicated appendicitis that you are treating operatively. Let's go right to the operating room. What's your approach today, and do you have any technique tricks you would like to share with the audience?
You know, we do continue to treat the vast majority of our patients operatively, and so I'm glad you went down this path. Our typical approach currently is laparoscopic appendectomy for the vast majority of patients that come in with acute uncomplicated appendicitis. It's interesting that you would ask me specifically my surgical technique, because I do have a little bit different surgical approach than most of my colleagues, in that I utilize the fairly typical 3-port approach, but I actually do it a little different than most people in that I go ahead and place a Hassan in the periumbilical space. I place a 5-millimeter port in the suprapubic midline. I identify where the base of the appendix is and where the cecum is, and then I utilize a 12-millimeter OptiView somewhere in the right side of the abdomen. It typically is kind of right mid-abdomen, where I can then utilize a single endoscopic GIA staple load across both the base of the appendix as well as the mesoappendix. And so I'm basically doing a one staple load fire across both the base of the appendix and the mesoappendix. This allows me to get this accomplished, again, with just one staple load, which decreases cost, decreases time because I'm not having to dissect out the mesoappendix from the base of the appendix, and does not lead to any kind of an increased risk of complications that we've seen here. So it's one of those techniques that the students and residents, I always have to tell them exactly how we're going to do it, because most people are doing it a little bit differently.
So as the next step, you're going to use a SILS approach to do an appendectomy?
So certainly there are folks out there doing that. I don't think any of our group is using the SILS approach, but certainly it's been described, and I'll leave that to some other folks to work on.
All right, so let's say that patient comes in at night with that acute appendicitis that you're going to take to the operating room. Does the patient go home right after the operating room or the next morning, or do they all stay a day?
So we, at our institution, a few years ago, began a process whereby we do what we call fast-track appendectomies and cholecystectomies. And so our folks that come in with acute appendicitis go to the operating room. We try to get them there within 6 hours of presentation, consultation with the surgery team. And so that does mean in the middle of the night we are doing more and more appendectomies. And then we actually send them either to our observational unit or they may go to the floor. But either way, we plan to try to get them out within just basically another 6 hours after their procedure and get them home. We've been very successful in this, but the interventions that we really had to accomplish was just getting everybody on board, including the faculty, the residents, and probably most importantly, the nursing staff, in order to train them that these patients can go home within just a few hours of their operation. And we've been very happy with this. The patients are happy with it. And so we keep pushing the envelope and trying to decrease our length of stay with these patients.
Does that happen 7 days a week, i.e., are you successful with that approach on Saturday and Sunday admissions?
We are. Our biggest challenge is operating room availability, especially on the weekends when the operating room staffing is quite a bit lower. But in general, we are able to get patients, once we actually get them in the operating room, we're able to get them on out of the hospital in a pretty reasonable time.
And do you apply the same approach to an elderly patient who may have comorbidities, or do you have to be flexible with your protocol then?
Yeah, we do have to be flexible. Now, most of our patients are young and healthy coming in with appendicitis, so it's not as big of a deal, but we always take into consideration the patient factors. And that kind of leads me to one of my other little interests, which is frailty in the elderly. And so all of our elderly individuals come in and get a frailty assessment. And so based on that information, which is really just figuring out a good history and physical and social history and some functional components, we're able to get a good idea as to whether the patient's going to be safe going home or whether we might need to stay and work with them a little bit more before they go.
I realize there's a lot of frailty scores out there. Are you partial to one or another?
We actually have a kind of a modified Rothman index that we utilize here, and like you said, there are plenty of frailty scores out there that have been studied and continue to be studied. One of the things that I really like doing is a grip strength. And that is actually, we've got some unpublished data thus far showing the correlation of grip strength with likelihood of discharge home in our both emergency general surgery patients and trauma patients. And so utilizing some functional components to frailty as well as the typical history, I think does add to your abilities to be predictive.
Well, let's stay on appendicitis, but let's move up to something that has, I think, become more obvious in the literature at least, and that is complicated appendicitis. And especially this has come to the forefront when we start talking about non-operative management. But first, how do you differentiate between uncomplicated and complicated appendicitis?
Complicated appendicitis obviously can be challenging to identify both preoperatively and intraoperatively. You certainly see various surgeons describing various degrees of complicated appendicitis, and so I think this is kind of a challenging diagnosis to make. Certainly in my view, the clinical history and specifically the duration of the pain is very important in making that diagnosis. Also taking into consideration the age of the patient. As patients get older, it seems that their risk of complicated appendicitis does seem to go up for a multitude of reasons. And then also just the imaging, certainly looking for evidence of significant stranding and free fluid in the abdomen associated with appendiculis as well. And so I think you just have to have a high index of suspicion for complicated in those situations.
Let's talk about a common scenario, and that is you kind of mentioned the history. So let's take a history from the patient, and they come in after a week of lower abdominal pain, and you get called after the CT scan is done. I'm sure that happens to you just like it happens to most of our listeners. And they have what the radiologist is calling a periappendiceal phlegmon. The patient has right lower quadrant pain and maybe a little bit of localized peritonitis, high white blood cell count, but is not septic. What do you do with that patient?
So most patients with a phlegmon, I would say we will typically treat non-operatively, at least initially, and look for evidence of improvement of their overall clinical status. There are times where, a close review of the CT scan might tip us the other way to say this really doesn't look to us, just kind of given our experience in the operating room, doesn't look like it's going to be a significant phlegmon. Looks like it could be something that we could deal with surgically, taking a close look at where the base of the appendix is in comparison to the area of significant inflammation. It might push us to do operative management, but certainly if it's a significant phlegmon, I would generally recommend non-operative therapy, at least initially, with a course of antibiotics and close monitoring, of course. And you want to see that they're improving over the course of the next 24, 48 hours.
I guess I got to go there because you opened the door. So let's say you look at that CT scan, you say, oh yeah, I can get that appendix out, no problem. And you get to the operating room, and the base of the appendix is totally involved in the inflammatory response. What do you do then with your stapler?
Yeah, so this becomes, obviously, we've probably all been there. A lot of times we will go ahead, if you can get the cecum mobilized, which I think is a pretty important component in this situation. You really need to get the cecum mobilized. Then firing across a little bit of the cecum, I think, is very reasonable to do. And, the other reality is if you need to, you can always open. And if you have to do a little bit more dissection and resection, I think that that's a reasonable approach. But, every once in a while you get into a really bad situation and you end up having to do something as big as a right hemicolectomy, which, luckily haven't gotten into that situation recently anyways.
So when you fire that stapler across the cecum, how do you avoid obstructing the ileocecal valve?
Well, again, I think this is just making sure that you've identified and freed up the anatomy so that you are definitely, plenty far away from the ileocecal valve. And so I think it just really requires recognition of the anatomy and careful dissection and again, I think, really mobilizing things as much as possible to assure that you have that space.
You mentioned moving to an open procedure. Is this a time when you need to just swallow a little bit of your pride and just open?
Yeah, I think any time that you are, if you're struggling and you're questioning whether or not you are going to lead to a complication, if you're worried about the ureter, you're worried about the ileocecal valve, then, just open up and it's not a failure.
I know there's two outcomes after you treat them medically with antibiotics. So let's take one. Let's say you treat with antibiotics, they get better. They get really better, and their pain goes away. You are worried about residual phlegmon, and you get a CT scan, and lo and behold, everything is kind of melted away. The patient's anxious to go home. Do you talk to them about an interval appendectomy?
So, I typically do talk to them about it, but I recommend, in general, not doing interval appendectomies except for really one specific indication, which is the presence of a fecal lith. So if there was a fecal lith on presentation and we see that on the CT scan, then I generally do recommend an interval appendectomy. However, otherwise, our practice has not been to recommend interval appendectomies for the vast majority of our patients. Now, there is some controversy around that, and certainly one of the things that I do recommend in individuals over 50 is to get a colonoscopy after this is all resolved. So usually about 6 weeks after, we'll send them to GI for that. But the vast majority of people, we are not doing interval appendectomies on unless there's a very good reason. I think there are incidents of a recurrent episode. I think heads back down to basically the normal population. And, most of the time we don't see these people back. Now, of course, they could be going elsewhere. They're coming out to see you maybe. But, that's been our practice now for several years, and we've been pretty happy with it.
And the colonoscopy is not to look for any kind of inflammatory mass, but to look for cancer, obviously.
Correct.
Okay.
That's certainly the argument that some folks have used, the incidence of either cecal or appendiceal neoplasm to push them to do an interval appendectomy.
And if they develop an abscess that you treat by drainage and they get better, the same approach is used?
Correct.
Okay. Well, I really wanted to discuss the operative management of appendicitis, and you kind of set it up earlier by saying that you still operate on most cases of appendicitis. But let's take a step backward, or I don't know, maybe it's a step forward. But you have a patient who has read the latest stuff on the web and wants to be treated with antibiotics. How does that discussion go in your practice?
Generally, I do think that non-operative therapy is safe, and so I think that that's the beauty of the studies that have come out, is that we know that it's pretty safe to do. And so, I tell people that, again, we would recommend an appendectomy at this time. However, you could be treated medically, and the likelihood that this is going to resolve, at least acutely, is pretty high. But we do know that people end up coming back about 30% of the time with recurrent appendicitis sometime within the next year. And so, I certainly am respectful of patients' wishes, and if they say, gosh, I just don't want an operation, and I'm willing to take that chance, I don't argue with them at all. I say, okay, I think that's reasonable to do. But like I said, I typically try to encourage them to go ahead and proceed with an operation at the time of the initial presentation.
The question I hear that's asked in surgeons' lounges is, okay, so you got a CT scan that is consistent with a little bit of appendicitis, a little bit of inflammation in the right lower quadrant, but there's a fecal lith. Does that change your approach?
Yeah, so the presence of a fecal lith, certainly the data in regards to non-operative therapy would show that you have an increased risk for failure. And so in the presence of a fecal lith, again, I would recommend and probably be a little bit more strongly recommending to the patient that they go ahead and get their appendix out at that time.
So that goes back to your use of a definition for uncomplicated and complicated appendicitis. Fair?
Right. Correct. Yes.
Okay. If you decide on medical therapy, how long do you treat?
Well, that's a little bit of a crapshoot, and I think, generally we'll treat for somewhere between 7 and 10 days, and generally see the patient back. They'll typically end up staying in the hospital for probably about 3 days or so, generally starting off on IV antibiotics and then transitioning to oral antibiotics. And so I would say that a lot of these folks will, and again, we don't treat too many like this, and so a lot of these folks will probably end up on somewhere between 7 and 10 days of antibiotics.
All right, well, it's time to switch topics. Let's talk about biliary disease. First question, do you believe in biliary dyskinesia? Why are you laughing?
Am I a believer? Well, I do think that there probably is such a thing as biliary dyskinesia. Certainly a lot of smarter people than I have written about it. Luckily, we don't see too many of these patients anymore. I think when I started my practice here, we would see a few of these folks here and there, but I haven't seen a patient like this in actually a number of years. It's a conundrum as to what to do and how far to push the workup, and then what to do in counseling the patient as you end up getting the information from the workup. And
your workup includes what?
Well, generally we would obviously you'd have an ultrasound demonstrating no evidence of stones. You would have the typical good history and physical, which it's going to sound a lot like biliary colic. It's going to look like that. You're going to have nausea and vomiting. You'll have the pain radiating to the back, but again, you're not going to see any kind of structural problems in the biliary tree based on ultrasound. Not going to see any gallstones. And so I think, the vast majority of these folks will end up getting a HIDA scan, which, I know that folks talk about then utilizing that information in making the next step of whether or not to do something like sphincter vodi manometry. I will say that I don't really have any experience with that, luckily, and so again, I think a lot of these folks, when you sit down and talk to them, one of the things that I generally am always looking for is evidence of possible peptic ulcer disease as a different differential. And so many of these folks in my hands end up getting an upper endoscopy looking at that, and certainly I've found a number of individuals either with or without gallstones that ultimately have a different diagnosis other than the elusive biliary dyskinesia.
Well, there's a question on the Rome 3 guidelines in CSAP 17 that we had a lot of discussion on about whether or not to include. This is now Rome 3, so there's got to have been a Rome 1 and a Rome 2. So I'm assuming that you don't use the Rome 3 guidelines or criteria in any kind of formal approach to evaluate a patient who comes in with what may be biliary dyskinesia?
Yeah, I think that's a correct assumption.
Okay. They're pretty vague and could be almost anybody who comes in with abdominal pain into the emergency room, which I'm sure you're asked to see a lot of.
Right. Yeah, absolutely.
So you've already kind of mentioned and answered the question that I would have next is when you take that patient with acute cholecystitis, that you really do have a diagnosis, and you go to the OR and take out the gallbladder, does that patient, when they come in at night, do they go to the operating room right away, wait until morning, and how long do they stay?
Yeah, so along with acute appendicitis, we made the decision to try to get our gallbladders taken care of in an expedited fashion. And so they are going to the operating room in the middle of the night now. We have a system whereby we can accomplish that. At this point, we have 2 of our acute care surgery faculty in-house at nighttime, which allows us that kind of flexibility to be still available to do traumas as well as do these hopefully shorter cases in the middle of the night. And so we'll go ahead and get them in the operating room and again try to get them out of the hospital within about basically a 6-hour period as well.
So let me ask you the $64,000 question. Acute cholecystitis, straightforward, but there's always in the back of our minds as we take that patient to the operating room, what about a common bile duct stone? So do you have any lab values that would push you to delay the case besides obviously clinical hyperbilirubinemia or clinical jaundice that you could share with us?
Several years ago, in preparation for our fast track protocol, we utilized, I think it's the 2010 guidelines from the American Society of Gastrointestinal Endoscopy, looking at the moderate, strong, and very strong predictors for choledocholithiasis. And so utilizing that as our frame of reference, we generally utilize bilirubin as a strong or a very strong predictor. And so looking at a bilirubin somewhere between 1.8 to 4 as being a strong predictor and over 4 as being a very strong predictor. And then also, I think probably even more importantly is looking at the ultrasound results. And so we look at the ultrasound and look for a common bile duct that's greater than 6 millimeters in size, or obviously presence of a stone seen in the common bile duct on ultrasound. And so based on those criteria, then we make a determination, again, this is using the guideline from 2010, as to whether somebody is going to be low, intermediate, or high risk. And so our low and intermediate risk individuals, we generally will go ahead and take to the operating room and make a decision as to whether or not to do an intraoperative cholangiogram. Obviously well, I shouldn't say obviously, but we do not do routine intraoperative cholangiograms on folks. But if they are an intermediate and certainly a high risk that ends up in the operating for some reason, we will do an intraoperative cholangiogram, and then based on that, make the decision as to how to proceed.
And let's say that intraoperative cholangiogram is positive. Do you do a intraoperative expiration, or do you close and get ERC postoperatively?
This is where my age and experience has taught me a few things. And that is, for somebody who does appear to have a stone that does look retrievable on ERCP, and certainly we're lucky to have a very good team of gastroenterologists here to do our ERCP, so our success rate is very high. I do not mess around anymore doing common bile duct explorations. I have wasted way too many gastric mucosal cells of my own in time in doing those, and so just I think that's probably an institutional decision, but generally the vast majority of these will try to get a ERCP done to deal with the stone after the operation itself.
Well, let me just ask you a what-if question. What happens at your institution when somebody has to do an open common bile duct exploration for biliary tract disease?
So generally, if we have to do an open, I think it depends on whose patient it is, and so if it's one of our team, we may double scrub it to give some assistance because there's just not that many of them done anymore. Alternatively, we may end up getting the hepatobiliary surgeons to assist. I've done, I think, maybe 3 since I've been a faculty, and 2 of them were extremely difficult and very challenging, and just due to the enormous size of the stone, patient body habitus. And so, I think, again, swallowing pride and getting help from people who are in that region operating all the time is going to be the right approach.
As a teaching institution, I bet the room is crowded. Fair?
Yeah, there's going to be a few people watching.
Okay. Which raises the stakes a bit. So. Right.
Yeah, you got to look like you know what you're doing.
Okay. How about biliary pancreatitis, where it's related to biliary tract disease? So how do you make the diagnosis, and what test do you normally use when you're thinking about that diagnosis?
Well, so, an individual that comes in with suspected pancreatitis, obviously, they're going to be seen in the emergency department, so they'll go ahead and get their, we typically just rely on a lipase, as well as, the other common lab values that we're always going to be looking at, CBC and BMP. But, once we make the diagnosis of pancreatitis, I always want to have an ultrasound to take a look at the gallbladder, and again, looking for any evidence of choledochal lithiasis, but also, I think just as important is just looking for any evidence of stones in the gallbladder. And certainly, my index of suspicion for biliary pancreatitis is going to go up when I see, a bunch of small stones in the gallbladder, as those are going to be more likely to have passed on into the common bile duct and gotten lodged at the ampulla and so that's really the typical beginnings of the evaluation, is just your basic lab workup, a lipase, and an ultrasound. Certainly always wanting to know the social history of any kind of alcohol use, drugs, and if we generally, if we see stones, we don't head down the path of looking at triglycerides and such, but certainly if there's no stones, we definitely are going to look at that.
Well, let's say you got the typical patient. You've got small stones. You got a CT scan that shows a little bit of inflammation, but a nicely perfused pancreas. They've got a little epigastric pain. You put them in the hospital, make them NPO, and how do you follow that patient? More imaging? Do you do an operation on that admission?
Yeah, so certainly we want to try to get the gallbladder out during that same hospitalization. So luckily, the vast majority of these folks, their pain seems to resolve within 24, 48 hours. And so I'd say most of our folks end up getting a lap chole within probably about 2-3 days, probably at the max. And all we're looking for is evidence of improvement of the physical exam. So we're not following serial lipases, and we're looking at their overall clinical status. So if they're improving clinically, hemodynamically, making good urine output, they're feeling better, then generally we'll just base it on that.
Not all biliary pancreatitis stop there, and let's talk about one that develops a pseudocyst. And they come back in on, I don't know, sometime later in the future. You've treated them, their gallbladder is out, but now they complain a little bit of epigastric pain again. The CT scan shows that you've got let's say a 5-centimeter pseudocyst in a retrogastric position. How do you manage that?
Just to clarify, you're saying that this is something that's at least 4 weeks out?
Yeah, at 4. Let's say it's 4 to 5 weeks out. Yeah.
Okay, sure. The general practice for these is to watch them. So if they're just complaining of a little bit of maybe a little bit of fullness, a little bit of epigastric pain, generally I'll counsel the patient that this is pretty expected. Let's give this some time, and let's watch this. We may end up doing, based on their symptoms and such, may end up, needing some repeat imaging, another several weeks. But what we typically see is that the majority of these people get better. Now, if they're not getting better, or if they're just, they have significant appetite suppression, early satiety, abdominal pain, then we have really transitioned towards endoscopic drainage rather than kind of the classic cysgastrostomy for most of these folks, certainly with just simple pseudocysts. Now, if this was a situation where there is a significant amount of solid material associated with previous pancreatic necrosis, then we'll have a discussion with our gastroenterology colleagues. Again, I think we've got a really good group here, and so we can come to a conclusion as to whether we think that this could be managed endoscopically or whether we need to just go ahead and do a surgical cysgastrostomy and scoop out that dead tissue and get them healed up.
So for the simple pseudocyst, you're pretty happy with putting an endoscopic stent in through the stomach into the cyst?
Yeah, so we're pretty happy with it, and the literature would support that, and so I think that's a pretty reasonable approach at this time.
Okay, there was a very interesting discussion on the communities, the surgical communities, in the last 3 months, where they had a pseudocyst extension into the chest, and the discussion was whether you needed to drain the cyst in the chest as well as the cyst in the abdomen. I guess I'd ask, how does it go from the abdomen to the chest, and do you need to drain both?
What did the surgical community say?
Oh, we drained everything.
Well, pathology will find its way throughout the body. And so, I think it could certainly track retroperitoneally up and get up above the diaphragm in kind of various locations. But I would generally, our scans are pretty good now, so that we can see communication in little areas where where various seemingly loculated fluid collections are actually intercommunicating. And so I generally try to start fairly simply, and so I would start off just trying to drain the intra-abdominal component, and following that, and see what happens to the chest component or any other component that there might be, and kind of following a step-up approach to the management of say necrotizing pancreatitis and such. I have been very pleased with how people have responded to this type of a, I guess, very thoughtful stepwise progression in management. Such that we don't see nearly as many of these just catastrophic open abdomens and terrible situations as we used to with this type of a step-up approach.
I would just say I can distinctly remember a case back in my career where it was in the chest, and I thought we were going to have to do all sorts of things, and all it really took was proper drainage of the pseudocyst in the abdomen, and everything drained back out. So it started someplace, and it usually, if you start where it starts, it usually, just like a river, it usually will drain. So anyway, it was an interesting case, let's put it that way. So let's talk about one more thing related to severe pancreatitis, and that is you got a patient who you know is going to be there for a while, and you need to supply them with nutrition. What's your approach?
If you have a situation where they have some necrotizing pancreatitis, a lot of times these people be fairly sick. So we will generally start early with enteral nutrition, generally through a post-pyloric feeding tube.
I thought that was bad for pancreatitis.
No, I don't think that's correct. So, I think the reality is you can use enteral nutrition and monitor the response, and so we will start off with either tube feeds or even oral nutrition in some patients if they're not that severe. But certainly always trying to start off with enteral nutrition, monitoring the response and their tolerance of the tube feeds, and really utilizing TPN as a last resort.
Let's move on, and there's an interesting question about upper GI bleeding, and while most of these are managed non-operatively, let's walk through a scenario when the bleeding recurs after endoscopic intervention for a duodenal ulcer. What do you do next?
Typically, we will start off, and as you mentioned, luckily, most of these folks will respond to initial endoscopy. If they recur after their initial intervention, again, in open communication with our gastroenterologists and, what they saw exactly and whether or not they think that they'll be able to accomplish anything, we generally try to push them to go ahead and do a repeat intervention. And then if that fails, our next step nowadays has been to go to angiography with embolization.
What do they use to embolize? Is this with gel foam? Is this with coils? Or does it depend upon what they find?
I think it depends on what they find. I'm not sure exactly what they're using in every situation, but certainly I know that sometimes coils are used, and I think that sometimes gel foam is used. So, that's slightly out of my technical expertise. But certainly we have found that, again, luckily the vast majority of these folks can be managed non-surgically and seem to respond pretty well.
Let's go straight to your expertise. So the angio is done. They've had one repeat bleed that was solved by a repeat EGD. Angio is done, and lo and behold, they come back to the ICU and they're still bleeding. Do you go to the operating room?
Yeah.
And what do you do?
Well, you start with an upper midline incision.
Oh, that's the easy part.
Yeah, the one point I guess I would make is that recognizing when the other options have failed is very important. So not allowing a patient to flounder in shock and bleeding for extended periods of time is one of the potential downfalls of all of these non-surgical management options, is because I think we get lulled into the idea that, somebody else can kind of get this sorted out. We don't hardly ever have to operate on these folks, and so you can easily kind of talk yourself out of operating, but that certainly puts patients at high risk for complications. And so making that recognition and pulling the trigger in a timely manner is important. Once we get them to the operating room, again, based on the localization through endoscopy, through angiography, making an incision generally in the just post-pyloric area, opening up the duodenum, oversewing the posterior bleed, and then generally these folks, I'm going to end up doing a truncal vagotomy and pyloroplasty. Based on patient considerations as to why we believe that they've had this bleed. A lot of times, these folks will have not been on any kind of ulcer therapy, And so depending upon that, depending upon their age, depending upon what we believe is the underlying source, we'll make that decision as to whether we need to do the pyloroplasty and truncal vagotomy versus potentially just medical therapy with proton pump inhibitors.
Do you still use that U-stitch that's described in some of those old surgical textbooks?
Yeah, well, I don't know. I'm not sure if I'm doing exactly what they're doing, but yeah, yeah, I'm trying to, yes.
Okay, all right. And what if it seems to be associated with NSAID ingestion? Does that change your approach?
So if it is NSAID ingestion, then I'm going to be less likely and probably would not do the vagotomy and just do the opening of the duodenum and sewing of the artery.
Well, let's move on, and I know a favorite topic of yours is small bowel obstruction and its management. So is the management really changing?
Well, I do think it is changing, and certainly our practice has changed over my lifetime here, and we have certainly seen a decrease in the number of individuals that we're operating on based on our use of water-soluble contrast to both diagnose and provide a therapeutic benefit.
So how do you do that?
So our folks that come in with small bowel obstructions, I think there is still a little bit of controversy as to whether or not every single one of these needs a CT scan, but I will say that most of them ultimately do get a CT scan. I'll just tell you, how we do it here. Our initial CT scans are done without contrast. The diagnosis is made, so then we place an NG tube. Certainly, if clinical diagnosis does not suggest evidence of peritonitis and strangulation and such, then in the next few hours, generally within the next 12 hours, we will give water-soluble contrast and do a repeat KUB. So we just do that on the floor through the NG tube, and then just do a KUB in 6 hours. And if we see that contrast has passed into the cecum at that point or into the colon at that point, and if they're responding clinically, so obviously no nausea, vomiting, abdominal pain, and certainly if they're passing gas at this point, then we'll go ahead and pull the NG at that point and start slowly transitioning back to oral intake. If it does not pass into the colon, then we will wait for we'll wait for 24-hour film after the contrast went in and do the same thing. We've seen a decrease in the number of people that ultimately receive an operation, as well as we've seen a decrease in our length of stay in utilizing this. And actually, very importantly, I believe, is the decrease in time to surgery. And so what happens is that if you do not see contrast in the colon after that 24-hour contrast ingestion, then the patient has a very low likelihood of responding to non-operative therapy. So at that point, we go ahead and make the decision to proceed with an operation, again, for the vast majority of our patients.
So when you do this, you're dealing with adhesive small bowel obstruction as your diagnosis, and that's key to the application of this protocol?
Yes, absolutely.
Okay, all right. Now, let's say you have to go to the OR. Are you doing your exploration open all the time or laparoscopic all the time, or does it vary?
Well, I would say the majority of the patients will get an open procedure. There are some situations where we will try laparoscopic. My experience with laparoscopic is that there's a fairly high failure rate, and it's going to require the right patient who has decompressed dramatically. And, about the only time it works is when there's a single band that's just nice and and showing itself once you open up or once you get in there laparoscopic and blow up the belly and start to run the bowel. But I think the laparoscopic approach is very challenging. You have to be very careful not to injure the bowel. We use atraumatic graspers and run the bowel hand over hand, but when the bowel gets significantly dilated, it really thins out, and so I've certainly seen and or heard of enterotomies made doing that approach, and so you just have to be really careful. And again, somebody who has a significant amount of distension, so just based clinically as well as perhaps the initial CT scan. If they've got a lot of distension, then I generally will not, recommend laparoscopic approaches. It tends to just kind of be a waste of everybody's time.
Now, I have heard you talk about how to assess a safe entry point for an abdomen that's distended when you are going to try a laparoscopic. Can you give us some thoughts on that?
One of my kind of pet peeves is I do not recommend going through previous incisions when you're doing any kind of a laparoscopic entry. And so, anybody that's got a previous midline incision, I stay away from it laparoscopically. Even trying to do a Hassan type of open approach, it's just fraught with complications. And I just happened to have seen one just a couple weeks ago, and so I generally will do an OptiView approach, most likely in the left upper quadrant. I stay very close to the costal margin and apply retraction on the skin, so that kind of tense up the skin and the fascia, and just very carefully entering into the abdominal cavity. I've been very successful with that, but I think you do have to have some experience with it so that you know exactly the layers that you're heading through. And again, just recognizing that disaster awaits you if you end up getting a little off. And so I have certainly averted many potential disasters by staying away from those midline incisions.
Let's talk about another common procedure general surgeons do, and that is percutaneous endoscopic gastrostomy. And let's talk a little bit about complications. So you've done a great job putting one in, and you get a call in the early evening that the nurse says, "Well, it just fell out." What do you do?
Well, first of all, I want to know how long ago did I put this in?
Oh, just about 4 hours.
Oh, that stinks. So at that point, if it's an acutely placed tube, then I certainly would not try to replace it. And generally, what we would try to do is go ahead and take the patient back to the operating room to try to repeat the procedure. Certainly, some folks will say that even, after a couple weeks, that trying to replace a tube is not safe. And certainly, I would say that trying to replace a tube blindly is not safe, even after a couple weeks. But, once you have a bit of a track, then I think you can, most of the time what we'll end up doing is trying to do this under radiologic guidance, asking our interventional radiologist to try to slide a wire in and confirm its placement that way.
Well, now, wait a minute. We said 2 weeks, so what if it's 3 weeks? What's the time here that you can use that little wire technique or even a blind technique?
So let's go to the blind one. That I could certainly be less controversial if I said you can. So certainly after, I would say 4 to 6 weeks, probably 4 weeks, you could probably blindly place the tube and assure yourself that you have good placement. And depending upon how that replacement went, you could do one of two things. If you want to be extremely safe, you could do a contrast injection and make sure that it's in the stomach. If you want to be a little bit more cavalier, if you have easy return of gastric fluid, then I would say you're probably, in all likelihood, going to be okay. But certainly, again, I think from just from a safety standpoint, somebody in the less than 6-week time period, certainly in that 4 to 6 week time period, I think probably getting a radiographic study is going to be the safest approach.
So before 4 weeks, you would take them back to the operating room and try to look and redo the procedure.
Yeah, so I would say, again, this is why you have this as a controversial conversation with me. It's a judgment call, but I think, in that probably the 2 to 4 week time period, I would probably try to see if they can put a wire in. I think certainly in the less than 2 week time period, they're going to need to go back to the operating room to have it dealt with. But depending on the patient habitus, if the tract looks, like it's healing well, then, in that 2 to 4 week time period, I think I would be willing to try to get interventional to place it, recognizing that, I think your failure rate's going to be fairly high. So you might want to just go ahead and get them posted.
Okay, all right. And then do you do that laparoscopically or endoscopically or both?
I'd say that the majority of these I just do endoscopically, but I know some of my colleagues would probably approach it laparoscopically.
Well, let's talk about another problem that PEG tubes sometimes present with, and that's something called the buried bumper syndrome. Sounds like something in a baby crib. What's that?
Well, the buried bumpers are a situation where the bumper has migrated generally through the gastric wall and is sitting somewhere in the abdominal wall. And generally, I think this is due to one of two situations. One, maybe the tube got pulled, partially pulled out inadvertently by who knows who. But that certainly happens. And then the other situation where we see it is where the tube was initially pulled up too tight, and so too much tension on that tube between the outer phalange and the bumper. So it just slowly kind of migrates through the gastric wall due to ischemia and tension, and ends up sitting somewhere in the abdominal wall.
So can you avoid that latter complication or that latter reason for the complication?
Yeah, so I think there's a couple important steps that can be done. Number one is by the surgeon at the time of placement, and that's, every time that we place a PEG tube, we, reinsert the scope after the tube is pulled up against the stomach wall, and we just look to see that the tube is being pulled up snug but not tight against the stomach wall, that it spins easily. And then we're always very careful to make sure that we are notating where that tube is sitting centimeter-wise at the skin level, and documenting that so that the team can monitor that. And then I think there's a couple other, maybe technical components. One, we do not place any dressings underneath the phalange, so that we're not going to increase any kind of tension by constantly pulling up on that and trying to replace gauze dressings or anything. And then from a nursing standpoint, having the nurses every day, or it could be the team, the residents or whomever, having them spin the tube on a daily basis, loosening it up from the skin as necessary, to assure that it is not, again, kind of gradually making its way up through the stomach wall.
Well, let's give you another scenario, and it's Friday afternoon, and it's one of your PEG patients, and they call from the nursing home, and they say something keeps coming out around the tube, and it doesn't look quite right, and they want to know if you'd see the patient, and lo and behold, they send him in just as clinic closes on Friday afternoon, and you've got a tube sticking out of the anterior abdominal wall, but you've got a subcutaneous abscess all around the tube, so it's being bathed in pus. What do you do? Does the tube have to come out? Does the patient need to go to the operating room? Just send them back home with oral antibiotics?
In general, going to need to pull out the tube. And certainly, if it looks like a significant infection at all, getting the tube out and draining the abscess is going to be important. We've certainly seen, necrotizing soft tissue infections associated with these. And so you don't want to ignore them. A lot of times the calls that we get are, so-called infections, but you take a look and it's just a little bit of cellulitis or hypergranulation tissue. And so most of the time, we're not seeing this type of complication, but certainly you have to keep your guard up and make sure that you don't ignore something that could be a true infection, abscess. And yes, I would go ahead and get the tube out, drain it, and then you can, once the cellulitis has improved or infection has improved, you can resite that G-tube, again, whether it's via open or peg tube or laparoscopic based on the clinical scenario.
Let's take an easy one, and you're in the operating room doing a laparotomy for some reason, and lo and behold, the patient has a Meckel's. What do? You ever leave it alone?
I thought you said this was easy. Yeah, so I don't think this is easy. I think this is somewhat controversial, and you're setting me up. I think that a lot of folks with Meckel's who are truly asymptomatic, so again, I think you said going in for an appendectomy. You go in for an appendectomy and you actually do have appendicitis, then I would probably leave that Meckel's alone for most patients. Now, I think there are some folks and some recommendations that for younger patients, certainly if you get in there and you see a Meckel's, certainly if you can kind of get a sense based on palpation with your graspers that there's a mass in it, or if it's of significant length, fairly long, then resecting it would be the right answer. But I think most of these folks, I would say I have not resected the Meckel's if I have gotten the appropriate diagnosis for the reason that I'm in there.
Travis, I couldn't agree with you more that I thought this was an easy question until CSAP 16 came out, and we had two questions, one using the SEER database to say that there was a measurable incidence of carcinoma in the Meckel's diverticulum, and therefore it should always be removed. I had more questions directed at me because of that question, I think, than almost anything else. So I think you're right. It's not always one size fits all. Travis, let's talk about, you said you did some abdominal wall work, and I want to talk about prevention. And I want your comments truly about midline laparotomies and closure techniques. Do you have any strong thoughts?
I think you probably know that I do. So, several years ago when the data came out from Europe about small bite closure, I first heard about it right after I had been asked about closing abdominal wall fascia by a junior resident, and I emphatically had told them that, big bites, take big bites so that you're getting fascia and really, you bring it together. And then I saw this data and I felt kind of, embarrassed, a little stupid. And so I actually went to using small bite closure with 2-OPDS, so several years ago now, for all of my midline laparotomies. And I can tell you that I have made this point based on the literature to all my colleagues in various situations. Largely to no avail, though some people have gotten on the bandwagon, but it's kind of an interesting discussion. But, I have had some experiences with small bite closure in high-risk wounds, people who had eviscerated and just had horrible-looking fascia, and utilizing a small bite closure, even in that situation, I've had success. So that has only just bolstered my opinion that that's the right way to go. And so, people will argue, well, my patients are morbidly obese and this, that, and the other thing. They have other problems. They have, hasn't been all studied, but I'm going to bury myself here. The data will all come back differently in a few years, but I do think that that small bite closure is the right way to go.
So define small bite closure.
So generally, just to keep it simple, about 5 millimeters from the wound edge and from bite to bite. These are pretty small bites, so you could certainly say somewhere between about 0.5 to 1 centimeter and make that kind of your aim, but that's about what I'm aiming for. And again, I think it's not only the distance from the fascia to the stitch, but the distance between the stitches as well. And I have to say that when you've gotten that done with a 2.0 PDS, it just looks nice.
The inside looks nice.
Oh, it just looks beautiful, yeah.
And do you use a drain in the subcutaneous space at all?
Generally, do not use drains, though, if you are dealing with a potentially high-risk wound. Now, let me step back. So for hernias, and anybody who I have done any kind of mobilization, then yes, I do use a drain, and I drain pretty liberally. So if you're doing some sort of a TAR procedure or a component separation of any sort, or if you have raised subcutaneous flaps, then definitely putting a drain in is what I would suggest. But just a midline laparotomy in a clean or clean contaminated case, unless they've got other risk factors, then I generally would not leave a drain.
How about an incisional vac on these closures that you do?
Yeah, so I am a proponent of incisional vacs in high-risk wounds. I think this is a bit of a moving target. Right now, we're still trying to answer the question of what to do with dirty wounds and whether or not delayed primary closure, and then, if you're going to do a delayed primary closure, how are you going to close it, and are you going to put an incisional vac over top? Right now, what we do generally is we do a delayed primary closure, and then at about 3 to 5 days, we do that with a vac. So the initial closure is with a wound vac, and then we take that off, and then we close the skin in some manner, whether it's staples or using some sort of steri-strip type of device, and then we will place an incisional vac over top of that for another 5 days. It's all going to change as we continue to kind of try to figure out the best way to do this.
Well, it's been delightful talking to you this morning, Travis, but I see that our time is about up, and I really do thank you for spending your time with me to discuss these CSAP 17 topics. I guess I just ask any closing comments about the CSAP process or CSAP audio.
Well, I just want to thank you as well, and it's an honor to be involved, and it's a great deal of fun, and it's a learning experience getting together with colleagues from all over the country with expertise and not just expertise, opinions. And so, it's always a learning process, and really appreciate the opportunity to be involved in it.
Well, I thank you for your involvement, and you have a very nice day today.
Thank you so much.
That's the end of this session for this category of the CSAP 17 audio companion. This category will continue in the next session.